Thank you, Mr. Chairman, dear colleagues. So I have a quite difficult task. I'm going to talk about advanced perianal fistulas. And particularly, I would like to focus your attention on fistulas associated with perianal Crohn's disease. So I would like to outline some clinical concepts related to perianal Crohn's disease, also showing you differences between surgical, radiological, and clinical staging systems, showing you different ways of assessing the activity, clinical or radiological ways of assessing the activity. And finally, I would like to show you some example to underline the role of MRI in the management of this disease. And very lastly, I would like to address some differential diagnosis with Crohn's disease. Just to start, as Steve nicely showed before, one of the main pathogenic mechanisms for the development of a fistula is the inflammatory process at the level of the anal gland in the anal sphincter. And this is definitely one of the main pathogenic mechanisms leading to the spreading of fistula from this central area. But in Crohn's disease, as you know, there is another important mechanism, which is the transmural inflammation. The transmural inflammation is the typical inflammatory process of Crohn's disease at any level of the intestinal tract, and it may act at the level of the anal canal as well, producing fissures, penetrating fissure that may extend from the mucosa to both mucosa layers and spreading out to the fat tissue. Whatever it is, the mechanism may be, one, the other, or both, the result is this. In Crohn's disease, we have very severe fistulizing perianal disease. In the majority of cases, we find complex fistulas. Differently from the general population, where the incidence is what Steve just said, about 0.01%, in Crohn's disease patients, this disease has a very high incidence and prevalence. Approximately 40% of patients experience the disease. The incidence range between 5 and 80% according to different series, but it's been reported that the lifetime risk of developing a fistula is approximately 20 to 40% in these patients. And very interestingly, in many cases, fistula are the first symptoms of a Crohn's disease. They may appear several years before the onset of intestinal symptoms, and in very few cases, they may be the only symptoms, the only finding of a Crohn's disease. Interestingly, they should be considered, as a matter of fact, as a part of the so-called fistulizing course of Crohn's disease. Gastroenterologists, as you know, have divided the Crohn's disease into three main phenotypes or courses, one inflammatory, one fistulizing, and one stricturing. And of course, perianal disease are symptoms and signs of the fistulizing course, together with the enteroenteric fistulas and rectovaginal fistula or enterocutaneous fistulas and other different types of fistula. This is a typical example of a fistulizing Crohn's disease where you may observe very severe fistulizing enteric disease at the level of the mid-ileum, very active disease associated with severe perianal disease. This is a typical case of fistulizing disease. And another very interesting point that was outlined by Ehlers and co-worker in this important paper is that fistulas, perianal fistula, are associated with distal Crohn's disease. In other words, in purely ileal Crohn's disease, they are quite rare. They become more and more frequent in colonic Crohn's disease, in ileocolonic Crohn's disease, in purely colonic Crohn's disease, and they are present in approximately 92% of cases in colorectal Crohn's disease. So these are important clinical issues related to perianal fistula and Crohn's disease, and a very important point I would like to outline in all this lecture is that perianal disease should be considered always a very severe complication of Crohn's disease. They denote an aggressive Crohn's disease course, and they should be considered a very negative prognostic factor in this disease, with a very significant risk of disabling disease, in other words, not responding disease, or need of several surgical interventions. To remind you, once again, the main surgical, clinical, and radiological classification, I don't want to go too deep inside this classification that has been very nicely and accurately described by Steve. I just remind you that we have a very important and widely used surgical classification, which is the Parks one, which consider four main types of fistulas: the intrasphincteric fistula passing between the two sphincters, the suprasphincteric fistula, the transsphincteric, and the translevator fistulas. And this part classification has been very nicely related to MRI-based classification, which has been developed in the St. James Hospital, which is almost overlapping, but it just divided the first two grades into two subgrades, if you want. In fact, the intrasphincteric type 1 is divided into grade 1 and 2, and grade 2 is associated with the presence of an abscess. The presence of an abscess, even small, is very important for a clinical point of view. And also the transsphincteric type 2, as you may see, are grade 3 and grade 4 in the St. James Hospital classification if the abscess is not present or present, whereas the type 3 or 4 are associated in the grade 5 of the St. James Hospital classification. Let me just show you a very few examples. This is a simple intrasphincteric fistula. This is so it's part 1, St. James Hospital 1. This is a small intrasphincteric abscess, part 1, St. James Hospital 2. This is instead a simple transsphincteric fistula, where you may see the fistula crosses both the internal and external sphincters. And this is part 2, St. James Hospital, grade 3. If we find an abscess, will become grade 4 of the St. James Hospital, such in this case. This is a large, is a collection, is a fluid collection, and this is a transsphincteric abscess, grade 4, St. James Hospital. This again is a complex transsphincteric fistula, always Parks 2, but St. James Hospital, grade 4. This is a complex also transsphincteric fistula with multiple abscesses. And finally, this is the rare suprasphincteric fistula, which crosses between the two planes and finally may develop an abscess just above the puboretali muscle, as in this, nicely shown in this picture. This is a small abscess, and this is St. James Hospital, grade 5 and Parks 3. And finally, the translevator fistula. Here you see the unhealed fistula. Here you see an active fistula involving the levator animuscle, are Parks 4 and St. James Hospital, grade 5. Why should we be so detailed in the morphological evaluation of fistula? Mostly if the patient has to undergo surgical intervention, because the end point of the surgical intervention are, on one side, the eradication of the fistulous tract, on the other side, preservation of the anal sphincter function. And for this, we need a very precise morphological analysis of the fistula and of the secondary tracts and of the abscess. And this can be reached with exploration under anesthesia and MRI, being MRI the gold standard. I don't want to go through the different interventions, but from the placement of a seton, a simple seton, to the fistulotomy, to the fistulectomy, of course, the detailed knowledge of the tract, of the internal and external opening, of the relationship of the fistula with the sphincter is mandatory for the surgeon. And of course, surgery may also provide very extensive demolitive intervention, such as ileostomy and proctectomy for fistula. The position of the clinical association, American Clinical Association, is quite different from the surgical position. They divide and classify fistula in two simple categories. On one side, simple intersphincteric fistula, and on the other side, all the other fistula. So this is a very drastic division, and this is simple fistula, part 1, St. James Hospital 1. Complex fistula are enclosed parts 2 to 4, and St. James Hospital 2 to 5. Why do they divide so simply fistulas? Because this classification is based on the clinical outcome. It has been demonstrated that complex fistula required at least 6 treatments to heal, whereas a simple fistula can heal with 3 medical or surgical treatments. Complex fistula, in 50% of cases, need proctectomy, ileostomy, or colonic resection, whereas simple fistula just in the 6% of cases, approximately. And finally, 25% of complex fistula persist despite of any therapy. So these are the main issue of the clinical treatment. And clinical treatment, the endpoints, is of course the rapid healing, the elimination of all septic foci, and the reduction of the risk of recurrence. And to obtain this, of course, it's important the morphological evaluation of the fistula, but it's also extremely important the assessment of the fistula activity and the evaluation of possible abscesses associated with fistula. I would like just to remind you that the clinical therapy is not only based on antibiotics, such as in a conventional fistula, but in fistula associated with Crohn's disease, it's based on the use of immunosuppressant drugs, and particularly on the use of infliximab. Infliximab, when came out and was firstly used for fistula, seemed to be something very miraculous, since a very large fistula could heal completely in a couple of weeks. But then was very clear after a while that despite the closure of the external opening, internally the fistula persisted. And this caused frequent recurrency, particularly after the end of the infliximab infusion, infliximab therapy. So for this reason, the two main clinical indexes for the assessment of activity, that are the fistula drainage assessment and the perianal Crohn's disease activity index, are not extremely adequate and satisfactory in evaluating the fistula, and there is a large consensus also on between the gastroenterologists that MRI is the tool to assess the persistence and the activity of the fistula. A definitive, validated MRI score for the assessment of fistula activity is not available yet. This score has been proposed by Von Asch and is mostly based on tissue-weighted imaging. Other authors have proposed a primary role of contrast enhancement in the evaluation of fistula activity. Anyhow, what is important to remember here is that the resolution of perianal inflammation at MRI is consistently lower than the clinical healing, and the persistence of tissue-weighted signal intensity and contrast enhancement is a sign of incomplete healing. Instead, when radiological resolution is achieved, usually the fistula is in remission. So this is a very important point. Here you may see a persistent bright signal. This is probably not completely healed fistula, and here you may see a complete healing of a fistula. So MRI is extremely important in the therapy decision-making process, either for surgical planning and for the pharmacological choice of the proper treatment and for monitoring the effect of the therapy. And let me just show a few cases to point out this, to outline this point. This is a very young boy with an active ileocecal Crohn's disease, who was candidate to the infliximab treatment. Here you may see the typical signs of ileocecal Crohn's disease, but during this scan we also observe intrasphincteric abscess. This was very clear, and we further evaluate this abscess with more detailed images. This was a complete contraindication to infliximab. So these images changed completely the management of this patient who underwent antibiotic treatment and subsequently to infliximab. So this case demonstrates us that MRI may play a primary role in the therapy decision-making process. That is the only diagnostic tool which can evaluate at the same time intestinal perianal Crohn's disease, and that it's very important to perform a fast scan of the perianal region every time you study a patient with MRI, and be very and please rule out the presence of abscess when infliximab therapy is prospected, is suggested in these patients. This is another case, once again, a very young boy with a severe a mild ileocolonic disease, who, after a few years, at the age of 11 years, developed an extremely severe disease of the perianal region. And I can show you just in a movie because it's so extensive that it's very difficult to show you in single slide such extensive perianal Crohn's disease. And this patient also had swallowing of the left leg, and in fact, MRI showed a diffuse inflammation and abscesses in the muscular compartment of the left leg. So this patient underwent multiple drainages. So the take-home message is, with a small abscess, antibiotics may be valuable. Larger abscess need percutaneous drainage. This is another case of a very severe and active disease in a very young female girl who underwent ileocecal resection at 15 years and had recurrent Crohn's disease at the level of the anastomotic region, but also very severe proctitis, and who developed this supralevator fistula, as you may clearly, fistula with abscess, as you may clearly see here. She underwent a very strong therapy with immunosuppressants, immunomodulating drugs, and ceton, and she had complete remission of Crohn's disease up to now. I just examined her a few days ago, but a few days ago also she had this very active intestinal disease, very severe disease of the sigmoid colon, of the ileum, and of the rectum. So these are very severe patients. The take-home message is that pediatric patients have a very aggressive course. The colonic localization is more frequent, and colorectal disease is strongly associated with perianal fistula. Flare-ups of perianal fistula and intestinal disease may coexist or be independent. So don't forget that they are frequent complications because they frequently recur after therapy. Symptoms get worse, and despite of therapy, they may lead to functional problems, to temporary ileostomy, and to definitive ileostomy. MRI has a very important role to detect the disease in unsuspected patients, to stage perianal disease, of course, to assess disease activity, and to monitor the response to pharmacological and surgical treatments. And just very, very quickly, a few differential diagnoses, and probably the most important is with hidradenitis suppurativa, which is a chronic inflammatory disease of the skin of the derma due to infection of apocrine glands, which affect the perineum, the perianal region, and axilla, and may be unrespondent to medical treatment, sometimes can be treated only surgically with large amputations. Sometimes it may be associated with Crohn's disease, and this makes the difference very difficult. Sometimes it may lead to a cancer. And let me show you a very dramatic case we had in our experience. This was a young lady with a very severe perianal disease, which was treated for a very long time with infliximab because she refused completely proctectomy and ileostomy. And after a few years, the disease was so severe that was associated with this very important inflammatory process of the perianal region. Unfortunately, no treatment was possible, no antibiotics treatment or any other type of treatment. She developed liver abscess, lung abscess, and she died subsequently of diffuse infection and sepsis. Some sexually transmitted disease may develop fistula, particularly when syphilis is present. We know the syphilis may determine a very severe proctitis, and sometimes patients, particularly if immunosuppressant, may develop a disease which may mimic and may overlap some aspects of Crohn's disease. I will not spend so much time for showing you the differential diagnosis with pilonidal sinus fistula because the colleague just showed very nicely these cases. I just remind you that usually the sepsis in pilonidal sinus is confined to the coccyx, to the subcutaneous tissue overlying the coccyx and the sacrum, and they do not involve the anal sphincter, of course, like you may see very nicely in this case. But sometimes, as Steve Halligan and Stuart Terry published, sometimes these may not be exactly the case because the disease may spread towards the anal canal, so mimicking exactly a perianal fistula. So to conclude, I would like to remind you that complex fistula occur in complex Crohn's disease, that perianal fistula is associated usually with colorectal Crohn's disease, with fistulizing Crohn's disease, and with very severe. It may occur during flare-ups. It's very frequent and more severe in children and younger adults. It has a very challenging clinical management, a very high rate of recurrence, and may lead, unfortunately, to total proctectomy and ileostomy. MRI is the gold standard for the diagnosis, for the preoperative staging, for the assessment of activity, for the follow-up after medical or surgical treatment. Don't forget that for fistula healing, for the evaluation of the healing, MRI is the gold standard at the moment, and differential diagnosis should include, first of all, hidradenitis. Thank you for your attention.